Today we will be talking about oncopathology and its role in making diagnosis and guiding treatment decisions. Cancer is one of the leading causes of mortality in the world and its incidence is continuously on the rise. But not all cancers are equally aggressive. Many cancers, if diagnosed early and treated adequately, they allow the patients to lead a near normal lifespan. Cancer management is a multidisciplinary process. It includes a combination of various different treatment modalities as well as diagnostic techniques. And in this era of personalized medicine, it is imperative to not just achieve a precise diagnosis of the tumor, but also to predict the various treatment outcomes and the prognosis of the patient as well. Now, this revolutionary treatment model has put pathologists more than ever before to the forefront of cancer diagnosis and influencing treatment decisions. So today, let's talk about oncopathology and its role in making the diagnosis as well as influencing the treatment decisions. Oncopathology is a branch of pathology that specifically deals with the study of cancer. Tissue diagnosis remains the gold standard in diagnosing a cancer even after the advent of so many sophisticated imaging technologies. It usually starts with a procedure called biopsy, in which the clinician removes a part of a tumor in the patient's body and sends that tissue to the histopathology laboratory. In the histopathology lab, the tissue is then processed into a machine called automated tissue processor. In this machine, the tissue passes through various reagent solutions which make the tissue hard while preserving its microstructure. Later on, the tissue is transferred into a paraffin wax and made into a paraffin block. Then multiple sections from the tumor can be cut through this paraffin block, and those sections can be picked onto a glass slide and stained with hematoxylin and eosin. And these slides are then analyzed by the pathologist. These tissue in these paraffin blocks, it can remain viable for many years. And we preserve these paraffin blocks of the patients for 10 years. And this helps in, to do any additional testing on the blocks, such as doing immunohistochemistry or molecular testing on the biopsy blocks, even many years after the biopsy was done. Now, before diving into more advanced applications in oncopathology, let's also first understand how tumor staging is done. The pathological tumor staging involves the examination of the entire tumor along with its margins, as well as additional organs and some regional lymph nodes which are present with the specimen. The pathological staging is done via a classification system which is called as TNM. T stands for tumor, N stands for node, and M stands for metastasis. So in this, first the diagnosis of the tumor is made by a biopsy. And then if the tumor is deemed operable by the surgeon, then he or she operates the tumor. He takes out the entire tumor along with its margins as well as the regional lymph nodes and any adjacent structures that might have been involved by the tumor. This entire specimen is then submitted to the histopathology laboratory and is analyzed by the pathologist. Then the pathologist, after analysis and after the complete microscopic examination of the specimen, it decides on the TNM staging of the tumor, by taking into consideration the tumor size, the extent of the tumor, the status of the regional lymph nodes, as well as status of any distant metastasis if the relevant tissue has been submitted. The pathological tumor staging forms a broad basis on which subsequent treatment decisions are decided upon by the treating oncologist. Now, cancer can usually be diagnosed by light microscopy alone without the need of any additional testing. But in many cases, a specific test called immunohistochemistry or IHC is required for one of the several reasons which I will discuss in a minute. So what is IHC? So IHC is a method of localizing specific antigens in the tissues or cells by means of antigen-antibody interactions which can be visualized microscopically by the formation of a colored end product. The antibodies in this context are called as markers. So there are numerous antibodies or markers which are available, and these can be broadly classified into three categories: diagnostic markers, prognostic markers, and predictive markers. Now, there is significant overlap between these three categories, but let's discuss them one by one. The diagnostic markers, as the name suggests, they are used in the specific diagnosis of a cancer. This includes not only diagnosing the type of cancer, but also diagnosing its subtype. Or maybe in some cases, it can also help in diagnosing the primary tumor site. Let's take example of lymphoma, which is a tumor of the infection-fighting white blood cells called lymphocytes. The tissue diagnosis of the lymphoma usually requires immunohistochemistry. But diagnosing a lymphoma is not enough. The clinician also needs to know the type of the lymphoma, the lineage of the lymphoma, whether it is of a B cell type or a T cell type. And within that lineage, they also want to know what is the subtype of the lymphoma and what is the grade of the lymphoma. So for all this information can be provided by doing a panel of immunohistochemical markers on the biopsy blocks. And taking another example, such as a carcinoma involving bone. So carcinoma is basically epithelial malignancy. Its presence in the bone signifies metastasis. So in this scenario, IHC markers can help in diagnosing the carcinoma and also determining the primary site from where this tumor might have spread. For example, breast or thyroid or lung. Now coming to the prognostic and the predictive IHC markers. The prognostic markers are those markers which are used to assess the prognosis of the tumor, that is, how aggressive it is. Then there are predictive markers. Predictive markers are those markers which are used to assess whether the tumor will respond to a particular treatment or not. Now let's look at some examples. Ki67 is a marker of proliferation. Higher grade tumors show more proliferation compared to the lower grade tumors. So by doing Ki67 on a tumor, we can determine its proliferation index. If it is high, above a certain extent, then it is a higher grade tumor. If it is below a certain extent, then it is a low grade tumor. Ki67 has a lot of applications, like we can do it in neuroendocrine tumors. In neuroendocrine tumors, from the treatment perspective, the grading is very important. So there are low grade neuroendocrine tumors and then there are high grade neuroendocrine tumors. So for this purpose, Ki67 is used. Also in lymphomas, we can do Ki67 to determine how aggressive a lymphoma is. Some lymphomas such as Burkitt lymphomas show nearly 100% proliferation index. So for all these tumors, Ki67 is a very important IHC. Another example of tumor worth mentioning in this context is breast cancer. Breast cancer is one of the very common cancers encountered in the clinical practice. Today, the treatment of breast cancer heavily relies on the use of the IHC to determine the biomarker status of the tumor. The three biomarkers, estrogen receptor or ER, progesterone receptor or PR, and HER2 are used almost universally to determine the prognosis of the tumor as well as predicting response to specific therapies. Breast cancers that are positive for ER and PR are considered prognostically good and they respond well to the hormonal therapies. ER and PR positive tumors generally show better prognosis and they respond favorably to the hormonal therapies. HER2 positive tumors are generally high grade, but they also show response to anti-HER2 targeted therapies, which are now widely available. The breast tumors which are negative for all these three markers, also called as the triple negative breast cancers, they do not respond to any of these above therapies and so they generally require chemotherapy. So in today's times, for the breast cancer management, the testing of ER, PR and HER2 by IHC has become indispensable. Another application of IHC is in screening for the cancer syndromes, such as Lynch syndrome. Lynch syndrome is an autosomal dominant hereditary disorder in which there is mutation in one of the DNA mismatch repair genes. This leads to the overaccumulation of mutations and increased risk of developing cancer. The most common cancers associated with this syndrome are colorectal cancer, ovarian cancer, endometrial cancer, or stomach cancer. A simple IHC panel comprising of 4 IHC markers called MLH1, MSH2, MSH6, and PMS2. This can tell if the tumor is mismatch repair deficient. If the tumor is mismatch repair deficient, then the patient can be counseled and further more specific genetic testing can be done to confirm the diagnosis of this syndrome. Now, newer IHC markers such as PDL1 are instrumental in choosing immunotherapy in select cases of cancer. Immunotherapy is a new form of therapy. It is a new form of treatment which helps the patient's own immune system to fight the cancer. The role and scope of immunotherapy is continuously expanding as more and more research is pouring in newer data. And hence this application of IHC is going to gain even more ground in the years to come. Advanced molecular testing such as next generation sequencing are already changing the landscape of cancer management by providing newer targets to develop specific targeted therapies. Already such targeted treatments are in widespread use in tumors such as lung cancer, melanomas, colorectal cancers. So as we saw so far, cancer treatment doesn't need to follow a one-size-fits-all approach. Through various oncopathologic tests, including IHC and molecular testing, a tailored approach can generally be devised for treating individual tumors in individual patients thus truly moving ahead in the era of personalized medicine. Thank you.